Hello, everybody. I'm Ron Waksman. This is the COVID-19 series on CRT Online. I have with me Dr. Tim Henry from Minneapolis. Welcome.
Yeah, great to be here, Ron.
Let me do it again. You're in Minneapolis, right?
No, Cincinnati.
No, Cincinnati. That's what I said. I said, wow, I messed up. Okay, I'll do it again. You work with Dean Kyriakis, right?
So I went after Minneapolis and I was at Cedars for 5 years.
I remember, yeah.
But now I just started at Christ with Dean Kyriakis. I'm at the Lindner Center.
Okay.
Which is fantastic, by the way.
No, I know. He's a terrific individual. And you have a great team there. I think Ian is there still.
Yeah, so Ian's here, Rob Riley, Tim Smith. I don't know if you know Tim. So really terrific young group of interventionalists. Really good.
Fantastic. Okay, so I'll do it again. Hello, everyone. I'm Ron Waksman. We are the COVID-19 series at CRT Online, and today we have one-on-one with Tim Henry from Christ Cincinnati. Welcome, Tim.
Thanks, Ron. It's delightful to be here.
And you recently wrote an interesting paper on experience with STEMI. I think it was in Jack, but you can remind me. Tell me a little bit about your experience with the STEMI during the COVID-19 pandemic.
Yeah, so Ron, I think it's been fascinating. First of all, I think that the impact on interventional cardiologists over the last month has been tremendous, and not in ways we didn't necessarily understand or anticipate. So it became, we normally, if you think about a viral pandemic like this, you would expect to see an increase in STEMI because stressful situations, stress cardiomyopathy, we know influenza that you get plaque rupture. So then COVID itself causes myocarditis with STEMI mimics that we know about. So if you looked at this, you would have expected to see a 20% increase in STEMI activation. But online, Twitter, other places, people kept saying, listen, where did our STEMIs go? And they, the so-called missing STEMIs. And so what we did is, we had also noticed it, but we put together 9 large regional STEMI systems, across the United States. It's kind of amazing. We got the data for March by April 1st from all these sites. By April 2nd, we had it analyzed and submitted to Jack. And by April 4th, it was accepted. And in fact, it showed 9 systems, and the STEMIs were decreased in all 9 systems. And it was interesting what we specifically did. So we got Beaumont in Detroit, which is a center. We got Northwell in New York City. We had Swedish in Seattle. So we had some high COVID prevalent places, but then we had some lower ones. So Springfield, Illinois had almost no COVID. And it was uniform reduction. Some were a little more, but and so then that stimulated, where did the STEMIs go? So that's the next phase of this.
So this is a very interesting observation. I did this so earlier, I think in April, there was at the Financial Times, there was the UK drop in ACS admission. It was like so impressive to see like huge fall. It's like plummeted of stock somewhere. I mean, it's just amazing. I think if I recall on your paper, it was an average of what, like 30% reduction?
40%, 38% actually.
Yeah, that's also impressive. So where did the STEMI go?
Yeah, so this is a next really interesting thing. So if you look, first of all, the observation's true in Spain, it's true in Italy, and it's true across the world, this reduction. So then the next thing that is consistent, it's a little harder to document exactly where they are, but I'll tell you my own personal thing. What you know now is that there's an increase in out-of-hospital cardiac arrest. There's an increase at deaths at home. So the New York Times had an article just this week that showed the number of the increased deaths in the United States had spiked in March, and it was almost double that of COVID deaths. which I think is due to not just cardiovascular, but what we know now is that the consequences of, we scared people to death, literally, Ron. We scared people to death. They're afraid to come to the hospital. And so we have a series of cases now we put together that we know that increase in out-of-hospital cardiac arrest in multiple places. There's an increase in late complications of STEMI. So we have a whole series, and I'll talk more about that in a minute, about this opportunity for people. But the increase in VSDs, in papillary muscle rupture, in LV thrombus, and in heart failure admissions. So at Christ, for example, in the last 10 days now, we've put in 6 Impellas and 2 VA ECMOs for cardiogenic shock, all basically late complications of presentations, and none of them are COVID.
Yeah, it's very impressive, and I agree. I mean, my own experience, the same. Patients are coming late, they're too complicated, their EF is already down. Some have a papillary muscle rupture. I mean, the question is, how do we change it? I know that there was an effort. I saw an ad from the American College of Cardiology. The ad was too complicated. I mean, like, where is the campaign to bring the patients back to the hospital and explain them that by sitting at home, they may not die from COVID, but most likely they'll die from heart attack.
Yeah, so this is a really interesting thing. As you know, I'll be president-elect for SCI, and so that's been a big part of our focus. SCI's had on multiple different levels. So number one, very quickly, and I'll say one of the things that's been really positive about this is the relationship between SCI and the Canadian Society of Interventionalists has never been stronger. I mean, we're working closely with them on multiple things. And then also with the American College of Cardiology, so that the Interventional Council and then ACC overall has been a tremendous cooperative venture. So as you know, we put together a document for initially for cardiac cath lab, considerations early on in March. And then we came back with a more formal, how do you approach acute myocardial infarction?
I like the second one. I think the second one, you dropped the thrombolytics almost to none. So that was a good one, because the first one, the thrombolytics was too much was overrated. But I think that correction, I mean, we all learn. I mean, so I think it's right now, it's concise. We actually follow more or less the same.
Yeah, so these are the things that I think that we've learned is, number one, a number of things. And we also have a task force working on exposure and safety in cath labs. And here's what it looks to me like, and we're documenting this. But if you look at, even in high COVID areas, and if people have an N95 and a face shield, it looks from our perspective that in the cath lab, it's safe and it's been a rare, if any, that people have converted. So we believe the best care is the best care, which is do primary PCI. You should take people to the hospital and do primary PCI. And in the first document, there was, this lytic thing, and actually the statement was, in rare circumstances, but it got taken out of context. And I'll tell you, there's strong reasons. I think it's worth talking about this now, and I think you feel the same way. There's the only place for lytics is if you are in a non-PCI hospital where you cannot get to the cath lab in a reasonable amount of time, which is the same indication it always is, right? But the issue with COVID and the paper that was in the New England Journal from New York,
Bangalore,
from Bangalore, was insightful for several things. First of all, about 40% of people never even went to the cath lab, and about half of the people developed the ST elevation in the hospital. So in-hospital STEMI is another unique part of this. But then when you looked at the angiograms, at least half have no clear culprit. So another reason not to give lytics is if you give lytics, it's not going to change the ST elevation. You end up being there for rescue anyway. So you give the patient the risk of lytics and you didn't change anything.
Yeah, no, I think that for the COVID-19, the lytics are really dangerous, especially when they have the cytokine storm. It's something that should be, but we learn. I mean, I think there were some, the reason probably for the lytics initially was not to expose the team to the virus.
Right.
But I agree with you. I mean, I'm not aware of people who worked in the cath lab doing cases that got infected. I'm sure there are, but not more than the usual population that work in a hospital environment. So I think that, and we're doing it on a daily basis. So we just had the grand rounds and we talked about our own policy. If you suspect the patient has a STEMI, then you bring him to the cath lab and you cath him. There is no reason not to do that and not to be afraid about being infected. The question is, you have all those, and you alluded to that, myocarditis, that EKG, they look almost like STEMI, not exactly classical. They have a chest tightness, with or without fever. And a lot of people say, well, I know that they're going to be normal. I mean, maybe they're not going to have with a severe culprit lesion. Why should I even bother to take them? This is like, oh, I know this guy even tested positive within a rapid test. So why should I take him? It's a myocarditis. So convince me why to take those patients to the cath lab.
Yeah, so I think here, this was one of the nicest things about the New England Journal article is they actually, in the supplement, put all the EKGs. I would challenge someone to look at those EKGs blindly and tell me that you can tell.
You cannot.
You can't. You cannot tell. And I will also say that there was one of them that I think they called normal coronaries, but to me, it looked like there was a diagonal lesion and there was lateral infarct. So I think it also depends on the eye of the beholder. But beyond myocarditis, we've seen stress cardiomyopathy. So another thing that can happen with ST elevation.
Tamponades.
Yeah, because it's obviously stress related, and certainly there's enough stress in the world right now. And spontaneous coronary dissection is also stress related, right? And you can see that for sure. But more importantly, we know the COVID people have this procoagulant thing and come in, and there's been multiple cases where COVID positive patients come in and have really thrombotic lesions. Everywhere. So not just, DVTs, pulmonary emboli, strokes, but also, coronary occlusions. So I think the best thing is, and we didn't know, I really think you're absolutely right. The problem is there's too many people criticizing people on both sides. You know something, nobody knew in February, nobody knew in January. There's plenty of, I think all of us, if we're really honest with ourselves, there are things we are right about. There are things we were wrong about. And that's true with physicians. It's true with government officials. And what we really need to do, though, is where are we now? What data do we have now? And then make good choices from where we are now.
Yeah, so one thing that I want to go back to that, I think, again, as someone that's going to be a president at Sky and very much involved with the societies, I think that the campaign should be not so much the physicians, but to patients. I mean, we have to make sure that patients understand that they don't sit on their symptoms when it's come to cardiac. And even if they're not sure, that should come. And many hospitals now trying to get some COVID-19 safe environment and to protect them. But it's something that we would have to work hard to convince them to come back to the hospital. Because the main thing that they don't, even if there will be lifting of the stay home policies, the patients, I'm afraid, still going to sit at home as long as they know the hospital has seen COVID patients. So that's one thing that.
That's really important. And I think you're going to like this. So we have a nationwide campaign that is directed directly at patients that's called Seconds Count. So, we've had Seconds Count for a long time of getting STEMI patients to come, but this should roll out next week where we talk specifically to patients. And again, it's with support of American College of Cardiology, American Heart. And I think I'll also say, so we're focusing on STEMI, but this is also true with structural heart disease, with stable coronary disease, with with EP, right? We've seen consequences of people not getting their typical cardiology care, and we have to turn it around.
Yeah. Let me ask you a little bit different topic. You're really expert in shock management, and many of the COVID patients, not necessarily related to STEMI, develop this shock. I mean, some of these are the cytokine storm, some of those are myocarditis. Where do you see today the mechanical support role, and what is your experience? Where to have it? Should we have it early on before the patients collapse? Should we have it only in a certain patients? How your hospital and your practice managing those shock patients that we see with COVID-19? And because we are cardiologists, we often called to take care of them.
Yeah. So first, it's terrific. It's a great question. And I will tell you, my personal feelings have evolved over the last month. And I'll tell you a little. So as to give the full spectrum with Sky, we have a registry for ST elevation that we're doing. And we have the registry for exposure. But a third registry is for mechanical circulatory support. And we had a tremendous group of people on the working group. And I listened to that working group of these young, aggressive interventional cardiologists. Ron, we can fix everything, right?
Yeah.
That's a view of intervention.
That's an optimistic approach. That's good.
And I will tell you, in my plenty of years as cardiology experience on this phone call, I had never, ever listened to cardiology being so, we can't fix this. But I will tell you, I've changed on that, and the experience now. So we have a registry where we're looking at mechanical circulatory support that will be up and running. And so anybody that has sites and wants to be involved in that, and that will include a balloon pump, Impella, tandem heart, VA ECMO, as well as VV ECMO. So now I'll tell you that I think when a hospital system or gets overwhelmed, then outcomes are not as good. Well, our experience with VV ECMO, and I can tell you around the country for just COVID, that has been our VV ECMO cases. I think we've had 4, and they're all off, and they've done well. So mine is that. The second issue is this, that just like with ST elevation, I think it can be difficult to tell. There was a case that Dave Cox told us about. Young woman was about a few months postpartum, but she had a viral illness, right? And they thought it was COVID. And she came into the hospital with cardiogenic shock. And she had an ejection fraction of about 20%. And but they were aggressive because she was in her 30s. And you know what? It was not. It was flu. So most likely this was a viral myocarditis, not COVID. She was COVID negative. They actually, in her case, did VA ECMO. She recovered, did fine. Her LV functions come back to normal. So again, you don't know that this is necessarily COVID. And one of the really interesting things about the registries are we're taking COVID positive and COVID suspected. And then what we're going to analyze is when you actually subsequently become positive or subsequently become negative. Because I think what happens is when you're COVID suspected, you get treated differently, even though you may not have COVID. And so it's an important thing. Again, it comes back to we're really good at what we've done. We've made such tremendous strides in the last 20 years, and we have to keep doing what we know works.
Yeah, so going back to that, for STEMI patients in our center, we treat them, all of them, potentially for COVID because we just don't know, and we don't have the time to do the test. So if they come with STEMI, and what is that means? That we treat them with primary PCI, but we fully protected with the PPE, we're taking all the precautions. Doesn't take much more time to put the double boots and to do, it's fine. If it's a non-STEMI, we have the time to check them. And then you can argue, okay, patient's stable, you can wait, you don't have to expose. That's maybe a separate story for the non-STEMIs who are stable non-STEMIs. And again, you have the time to check. If they are negative, you take them directly to the lab. If they're positive, you can wait. I mean, it's not like in a rush.
Yeah, I completely agree. So there's there is a subpart section of non-STEMIs that have hemodynamic ongoing pain or hemodynamically affected. But that's a small percentage, right? That's not the majority. And then there's patients that might have some high-risk features, but they're really stable. And then there's the other groups that are, really low risk. And I think this depends on where you are, what your current prevalence is, what your hospital resources are. And I think that should be a local decision but you have time to do testing and you have time to be thoughtful about that.
Okay, let me ask you a final question. How do you think all this will be perceived or change our practice post-pandemic, assuming pandemic will go away, let's say 2-3 months from now, we'll go all to meetings, but how that's going to change the practice in the hospital? Are there things that would be different, or are we going to go back to where we were before?
Yeah, I think that first, I think the lessons learned with PPE are really important. We have to have adequate PPE. We have to have supply chains in the United States that take care of this. That's essential. Every hospital has to have adequate PPE for their whole hospital, right? And then I think we need to learn about more about what that means. I mean, I will tell you, right, how many times when I was at Cedars was I tested for an N95 and it was painful. It was like, oh, why am I doing this, right? It was, well, I think we now take that a little more serious and realize why it's important. The second thing is, it's really a lesson that for the public, that we have to tell patients that we have to create an environment that's safe for them, and we have to tell them it's safe to be in the hospital. And we have to make sure it is safe to be in the hospital because they need care. I mean, we've seen now that this is, there's several people on structural lists who had to wait, who have done poorly and had bad outcomes because they had to wait. People on stable, who are, quote, electives, who have been admitted with acute coronary syndrome. We've seen, so if anything, you know what we've seen, Ron? What we do matters. What we do for patients matters. And so I think, and then the last thing I'll tell you is what we know works well, like primary PCI, stay with what works well.
Yeah, we don't have to improvise on that. But I do like your point. We have to make the hospitals as a safe environment for our patients.
Right.
We have to gain their trust again. I mean, we have to buy the trust from the patients so they can feel comfortable. And they come to us and they know that they're going to be protected. That's upon us to give them that assurances.
Yeah, it's essential. It really is.
Team, great talking to you. Thanks for all the great work that you do, the publication. Congratulations on this important paper at Jack and overall all the things that you're still planning. And I'm looking forward to see you in person, hopefully before the next CRT. Yeah,
I look forward to the time when we can all be together again. CRT was such a great meeting, and listen, this group of people that are our friends called interventional cardiologists is an amazing group of people, and we do better when we're together.
Thank you so much, and have a good day.
Yeah, you bet. See ya.